cancerous area. There is evidence that the cancerous cells are of B-cell lymphocyte origin. The Epstein-Barr virus also appears to be a factor, at least in some cases. Interleukin-13, a natural cytokine in the body, seems to be overproduced by the cancerous cells of this disease. While these factors contribute in some way, the cause of Hodgkin's disease is still being researched. Hodgkin's disease is rare in children under 5 years of age. In children under 10 years of age, it is more common in boys than in girls. Treatment approaches have improved remarkably in the recent years, and this disease now has a high survival rate. What are the signs and symptoms? The first sign of Hodgkin's disease is usually a painless swelling of one gland or a group of lymph glands, lasting for several weeks. The first glands to be affected are those in the neck, most often on one side only, and a small area above the collarbone. In some cases, enlarged glands can be felt in the axilla or the groin. Enlargement of the glands in the chest can cause a troublesome cough or dyspnea. Some children with Hodgkin's disease have a high fever, pruritus, or weight loss. Other signs and symptoms include anorexia, malaise, and night sweats. Diagnosis begins with a complete history and physical, and includes a CBC with differential and erythrocyte sedimentation rate to rule out infection of the lymph nodes. Part or all of a swollen lymph gland may be removed for biopsy to detect Reed-Sternberg cells. Further tests such as X-rays, CAT scans, MRI, and lymphangiography are done to establish the extent of the disease. This is called staging. If a blood test suggests that the bone marrow is affected by the cancer, a bone marrow sample may be taken. Medical treatment involves chemotherapy, sometimes with radiotherapy, and after treatment with chemotherapy, some children, particularly boys, are later infertile. Parents of teenage boys should be aware of the option of sperm banking. In this situation, sperm can be stored for possible use in later years. The parents should be encouraged to discuss the implications of treatment, such as common side effects and the possibility of future fertility problems, with the child's physician. There is also a small risk of developing a different cancer later in life as a result of treatment for Hodgkin's disease. Long-term survival for Hodgkin's disease is in all stages excellent. Your nursing care focuses on preparing the child for diagnostic and surgical procedures, teaching the child and family about the expected side effects of treatment, and child and family support. As the disease most often affects adolescents and young adults, be aware of the developmental and psychological needs related to this stage of life. You might also administer chemotherapy agents and help manage radiation and chemotherapy side effects and complications. The child may require sedation during radiation. Vomiting can be alleviated by antiemetics and diet. Pain management is an important concern, and you can intervene with non-pharmacological techniques such as relaxation or imagery, along with analgesics as prescribed. Other nursing care concerns include fluid and electrolyte balance, nutrition status and support, skin integrity, especially oral care, promotion of regular elimination, and protection against infection. The most common long-term side effect of treatment is a debilitating fatigue that can persist for as long as a year after treatment. What would your teaching for care at home include? Teaching about danger signs related to infection, skin breakdown, and nutritional deficiency. Administration of medications, the correct dose, time, route, and adverse effects. Include nutritional support, the use of any vascular access device or feeding tubes, community resources supporting families with children who have cancer, and referrals for nursing, nutritional, and pharmacological support at home. The family unit will need support and calm reassurance. After treatment is completed, the child will be reviewed regularly with scans and blood tests in the hospital. About 9 out of every 10 children who develop Hodgkin's disease are completely cured. Another blood disease affecting children is leukemia. Leukemia is a type of cancer that affects the blood-forming organs of the body, resulting in a proliferation of immature white blood cells. It is the most commonly occurring cancer in children, and is actually a broad term for a diverse group of chronic and acute malignancies. Early in the course of chronic leukemia, the abnormal blood cells can still function, and the child might not have any symptoms. But the problems appear as the number of leukemia cells in the blood rise. With acute leukemia, the blood cells are very abnormal and cannot function normally. The number of abnormal cells increases rapidly and symptoms develop and worsen very quickly. Who is at risk for leukemia? Risk factors include exposure to very high levels of radiation, as caused by the atomic bomb explosions during World War II and nuclear power plant accidents such as Chernobyl incident, chemical exposure, such as to benzene and formaldehyde, chemotherapy, Down syndrome, and certain other genetic diseases. Human T-cell leukemia, virus 1, which causes a rare type of chronic lymphocytic leukemia known as human T-cell leukemia, and myelodysplastic syndrome, which increases the risk of acute myeloid leukemia. Remember that most children who have known risk factors do not get leukemia, and many who do get the disease have none of these risk factors. What about the common signs and symptoms of leukemia? They are fevers or night sweats, frequent infections, weakness and fatigue, pallor and bleeding, and bruising easily, as manifested by bleeding gums, purplish patches in the skin, or tiny red spots under the skin. There may be pain in the bones or joints, hepatosplenomegaly, abdominal pain, and constipation. Swollen lymph nodes, especially in the neck or axilla, are common, as are weight loss, headache, lethargy, stiff neck, and irritability. There may be vomiting and anorexia, an unsteady gait, a low platelet count, and a white blood cell count above 100,000. Other symptoms of acute leukemia are confusion, loss of muscle control, and seizures. Leukemia cells can also collect in the testicles and cause swelling. Leukemia also can affect the kidney, lungs, GI tract, and other parts of the body. Of course, these are not definitive signs of leukemia. An infection or another problem also could cause these symptoms. Diagnosis begins with a physical exam, including information about the child's personal and family medical history. The healthcare provider will check for hepatosplenomegaly, lymphadenopathy, and order a CBC and platelets. There may be a biopsy, during which a bone marrow sample is extracted from the hip bone or another large bone, and the sample examined for the presence of cancer cells. A biopsy is the only sure way to know whether leukemia cells are in the bone marrow. Other tests include cytogenics, where chromosomes of cells are examined from samples of peripheral blood, bone marrow, lymph nodes, or cerebrospinal fluid. Chest x-rays are done to check for signs of disease in the chest. Depending on the type and extent of the disease, medical treatment consists of one or a combination of chemotherapy, biological therapy, radiation therapy, and bone marrow transplantation. The goal of treatment is to bring about a remission. Then, when signs and symptoms disappear, additional therapy, called maintenance therapy, is given to prevent relapses. Most children with leukemia receive chemotherapy to kill leukemia cells. Depending on the type of leukemia, a child may be given a single drug or a combination of 2 or more drugs. Chemotherapy drugs are administered by mouth, by injection directly into a peripheral IV site, through a central catheter avoiding the need for many injections, which can cause discomfort and injure veins and skin, or by injection directly into the cerebrospinal fluid. That last route is called intrathecal therapy, used because drugs given by IV injection or taken by mouth often do not reach cells in the brain and spinal cord due to the blood-brain barrier. For children, this type of treatment is administered through a special catheter called a Maya reservoir placed under the scalp. The physician injects the anti-cancer drugs into the catheter, avoiding the discomfort of injections into the spinal canal. Chemotherapy is administered in cycles, a treatment period, then a recovery period.